what has been your medical protocol regarding gabapentin, regarding pregabalin, oxcarbamazepine? What has been your choice, favorite choice?
So if the patient is of a lower socioeconomic strata, I would give carbamazepine to begin with. Otherwise, oxcarbamazepine or eslicarbamazepine. Dose I begin carbamazepine with 100 milligram BD, escalate it to 200 and go almost up to 400 BD and 400 TDS as well. But that is rare because nobody is able to, in India, tolerate carbamazepine at 400 milligram TDS. Very few patients. As far as oxcarbamazepine is concerned, again, I start with 150 or 300 milligram twice daily or thrice daily, and then up to 600. The maximum dose is 600 milligram TDS or 1800 milligram of total. Eslicarbamazepine has the advantage of it being a OD dosage. So generally about 400 to 600 milligram per day. So I start with that. That is the most important, most effective drug. The other drugs are lamotrigine, you have phenytoin sodium, you have gabapentin, you have baclofen. So these are the other drugs, but most of the patients, if they are coming to you for second opinion, they have already been using carbamazepine and gabapentins. So then you have lamotrigine, phenytoin sodium, and what else?
Pregabalin.
Pregabalin and gabapentin, they have already been on it.
What has been the dose that you have been using in gabapentin and pregabalin?
So gabapentin, again, 300 milligram BD or gabapen NT 200 milligram BD. So I start with that dose or pregabalin. So depending on his cardiac status and the edema.
And pregabalin, which is the maximum dose that you have ever given?
150 BD.
Pregabalin?
Pregabalin 150 BD, okay. Extended release.
Fine.
Mainly for failed back, not for trigeminals.
And when do you declare the patient refractory to medical treatment? What all combinations? After that you will say, no, we'll have to go in for a RF or MVD.
So basically the patient himself decides. He tells that either he is not getting relief or there are a lot of side effects of the drugs.
Thank you very much.
If we forget about the cost of these three drugs, carbamazepine, oxcarbamazepine and eslicarbamazepine, is there any difference in clinical efficacy of the pain relief these three drugs give, or they are nearly the same?
Okay, so it is not the clinical efficacy. Generally the efficacy is same, but as you know, when a new drug comes, they always project it to be either equal or better. Now, these newer drugs, their side effect profile is definitely better.
Okay.
So, as far as sedation is concerned, hyponatremia is concerned, and gait instabilities are concerned, this is lower with oxcarbamazepine and eslicarbamazepine.
Because this giddiness I have seen more than 200 BD carbamazepine giddiness is very openly seen, but this is not seen in the oxcarbamazepine or eslicarbamazepine.
Yes.
Second, in MVD.
Also, Rajiv, surprisingly, when you use it as an anti-epileptic drug for seizures, these patients do not complain a lot of sedation.
Correct.
But when you're using it for trigeminals, they come up with the problem of sedation.
Sedation and giddiness are quite routinely seen with carbamazepine. Second, MVD failures, can RF be an option?
Yeah. It is, as I told you, one of my indications has been failure of MVD. So I give RF. So it is interchangeable.
Okay. And if RF failure is there any difference in the MVD outcome, or it's still good?
So yes, MVD, one of the prognostic prognostic markers, one is the duration of the disease. Okay, so longer the duration, higher the failure. The number of procedures, more the number of procedures the patient has undertaken, the higher the risk of failure of that one which you are taking. So you mean to ask complete?
Debilitating complications of.
See, numbness is very common. It is one of the commonest, but these patients tend to recover. There have been a few of my patients who have had numbness for more than 6 to 18 months as well. But they have also come back to me when they had a recurrence. So they are ready to accept that.
precautions you need to take next time?
Okay, like I told you, one of my patients had diplopia and I was damaging her sixth nerve also both the time. So, but when I'm doing a repeat RF, my temperatures go a little higher up. And because the first one has failed, so I tend to go and I explain it to them that chances of complications might be little higher. So you need to be more, you have to give more time for counseling and consenting.
Thank you very much.
Thank you, sir.
Next speaker is, I think, my topic today is is there a role of DBS in neuralgias? मैं करता हूँ. So the simple